Hi everyone. Today we'll see about management of bronchial asthma in children. I am Dr. Suhas Kulkarni, Professor of Pediatrics, Patil Medical College, Kolhapur. I must acknowledge that the content of this video is based on China Guidelines 2024. Let us see what is asthma first, just to refresh our about this talk. The symptoms are wheezing, shortness of breath, chest tightness and cough, and it involves variable expiratory flow, difficulty in breathing air out of the lungs. Now, what is a pathophysiology? It is important to first rehearse our pathophysiology because it involves bronchoconstriction. Then it also has airway wall thickening, that is inflammation, and also there is an increased mucus secretion. Why this is important? Because many times bronchoconstriction is treated well, but the airway inflammation is sometimes not dealt with clearly, and that is why if we see the guidelines, we'll see one by one now. The management of asthma in children 6 to 11 years. If we see, then first we have to understand the steps of the different asthma. So we will first see what are the steps. So step 1 is symptoms less than twice a month. Step 2 is twice a month or more but less than daily. Step 3 is symptoms most of the days or waking with asthma once a week or more. Step 4 is symptoms most days or waking with asthma once a week and low lung function. Step 5 is uncontrolled asthma. So if we see the step 1, symptoms less than twice a month, and the second step is twice a month or more but less than daily. So the third step, symptoms most of the days, is usually when the patient will come to you and waking up with asthma. Step 4 is symptom most of the days or waking with asthma once a week or low lung function. And step 5 is uncontrolled asthma. So let us see one by one, we'll see what are the treatment options. So there are two pathways are given in these guidelines. So let us concentrate on treatment option 1. So low dose ICS taken whenever SABA is taken. So this is a paradigm shift in the thinking that now whenever we are giving a beta-2 agonist, like short acting beta-2 agonist, previously we used to give it singly, but now we want it to be given along with the low dose ICS. So the SABA should not be given without associated inhaled corticosteroids. So that is a new thing which has come up. And step 2 is daily low dose ICS. So here is a difference, that is step 1 involves as and when required you have to give SABA and ICS, but in step 2 you give low dose ICS for 3 months. And then you have to reassess the patient. Step 3, low dose ICS LABA or medium dose ICS or very low dose ICS formoterol. But if we actually see this here in the step 3, I will say that you move from daily low dose ICS to low dose ICS with LABA, and or you can double the dose or you can give ICS with formoterol. That is also now allowed in 6 to 11 years. For the step 4, if we see the medium dose ICS LABA, so from here you can see first is low dose ICS whenever required, second is daily low dose, third is low dose ICS with LABA, the fourth is medium dose ICS with LABA for 6 to 11 years, or you can give low dose ICS formoterol, that is marked, that is maintenance and reliever therapy. So, or if the patient is having almost daily symptoms or symptoms most days and waking with once a week with waking up and low lung function, then you may refer this patient for the expert advice. Step 5 is uncontrolled asthma, where you have to, it is better to refer this patient to the pediatric pulmonologist, because here we will require a phenotypic assessment, whether it is eosinophilic asthma, neutrophilic asthma, or any other phenotype, or associated obesity or something like that, and then the treatment will be given. So these are the different steps for the 6 to 11 years children with asthma. So it is easy to remember, as I have said, low dose ICS taken whenever SABA is taken. Second is daily low dose ICS. The step 3 is daily medium dose ICS or low dose ICS with LABA. Third is medium dose ICS with LABA, and the fifth one is referred to for phenotypic assessment. The treatment option 2, if we see, as needed SABA or ICS formoterol reliever can also be used in children, or daily LTRA. when the parents are not ready for taking the inhaled corticosteroid, because it is now very clear that MDI with spacer remains one of the important thing. But if the parents are not willing, you can give daily leukotriene receptor antagonists such as montelukast for step 2. But from the step 3 onwards, you have to introduce inhaled corticosteroids, because if the symptoms are daily, they will be better controlled with inhaled corticosteroid and not only with the leukotriene receptor antagonist. For step 4 in the option 2, you can add, along with ICS LABA, you can add tiotropium or LTRA. The tiotropium is a LAMA, that is long-acting muscarinic antagonist. So that can also be added, or LTRA continue. Step 5 is anti-IL-5 such as omalizumab can be added, or add low-dose oral corticosteroids can be added. But low-dose corticosteroids can give rise to side effects. So it is better to stick to option 1, where you can use MDI with spacer for the child with 6 to 11 years. But if there are some problems, you can go for option 2. And in this, you can use SABA as and needed, or ICS formoterol, either of them as a reliever therapy. If you go to the management of asthma in adolescent 12 years or more, for step 1, we use as needed only low-dose ICS formoterol. In the step 2, we use as needed only low-dose ICS formoterol. So here you can see that step 1 and step 2 have the same treatment, that is as needed low-dose ICS formoterol for the patients with less frequency of asthma in a month. If there are 1 or 2 attacks in 1 month, you can use as needed only low-dose ICS with formoterol. And in step 3, you can use low-dose maintenance ICS with formoterol. So here in step 3, you are giving a daily dose and not in the step 1 and step 2. Step 4, medium dose ICS with formoterol. So you double the dose. So you can use the same inhaler and use morning, evening. And for step 5, you can add LAMA or refer this patient again for consider, or you can use high dose, means you can make it 4 times. But usually it is not advised. It is better to refer, because if the patient is not controlled with medium dose ICS formoterol, usually it requires further evaluation by the pediatric pulmonologist. So this line of track 1 and track 2, out of that track 1 is very easy, as step 1 and 2 is as needed only low dose ICS formoterol. Step 2 is again the same. Step 3 is low dose maintenance ICS with formoterol. Step 4 is medium dose maintenance ICS formoterol. You just double the dose. Step 5, you refer. It is better. So this is the way, or you can add LAMA, that is tiotropium, to this our regime. In track 2, if you see, you can use ICS whenever SABA is taken, so that is same as the previous one. Step 2, you can use low dose maintenance. So here step 1 and step 2, it is different, not the same one. Low dose maintenance for at least minimum 3 months. Step 3, low dose maintenance ICS with LABA, so just an addition of LABA here. Step 4 is medium high dose maintenance ICS with LABA. And step 5, add on LAMA, or refer for assessment, or considers high dose maintenance or anti-IG, anti-ILR such as omalizumab, mepolizumab, and all these things. So if you follow track 1, step 1 and step 2, low dose ICS formoterol. Step 3, low dose maintenance ICS formoterol. Step 4, medium dose maintenance ICS formoterol. Step 5, add LAMA. So this is a one track. And take ICS whenever SABA is taken, low dose maintenance ICS, low dose maintenance ICS with LABA. So you are just adding something. And then step 4 is medium high dose maintenance ICS LABA. Step 5 is add LAMA or refer for assessment, or you can use further high dose. In all these, you have to give low dose ICS formoterol as a reliever therapy. So that is marked. So that is about the children who are 12 years and older. If we see the management in case of children 5 years and younger, here the steps are different. They are not same as the step 1, 2, 3, 4, 5 which has been described. Here the step 1 is infrequent viral wheezing, that is less than 3 episodes of viral wheezing. And here the first option is there is no further treatment has been given, because daily controlled dose is not required for this. But you can consider short intermittent course of inhaled corticosteroids may be given whenever there is an episode. Step 2 is is symptom pattern not consistent with asthma, but patient has more than 3 episodes, so requiring SABA. So here what you can do, you can give a trial of daily low dose inhaled corticosteroids. You can tell the parent that your child is, and I'm not sure whether he's suffering from asthma, but we'll give a trial of 3 months trial of low dose inhaled corticosteroids, and then if he gets better, then we may have to further investigate or continue with the treatment, and this can be given. So the step 3, you have to double the, so step 3 is asthma diagnosis, and so if the patient is getting recurrent attacks which are relieved by the SABA, and then if the patient is responding well to the low dose inhaled corticosteroids but is again getting attacks, then there is a asthma diagnosis can be done. And also you have to find out whether there is a family history of asthma, whether there is atopic dermatitis in the child. So there are certain additional points you have to find out, and then you have to make a diagnosis of asthma. So if asthma is not well controlled on low dose, then you may double the dose. So but the most important thing in all these medicines where you are using MDI with spacer or any other inhaler or any other mode of the therapy, you must check the inhaler skills of the patient. So you must first confirm the diagnosis, you must check the inhaler skills. Third is you have to check the adherence, if patient has really taken that treatment, and also exposure. Sometimes what happens, there is suppose the patient is exposed to dust and he's staying on his house is on the highway, so he will get a lot of dose of dust and he may have recurrent attacks. So you have to educate the parents about the different ways by which the patients are, especially the triggers like getting recurrent viral infections, dust or things like that. So that should be seen first, and then check the inhaler technique. Ask the parents to bring every time the inhaler, MDI inhaler with spacer, and demonstrate this rather than asking them, so that if there are any discrepancies you can remove them. And third is you have to ask them to keep a record how many days out of 30 days he has taken that, so that you can make a rational decision regarding stepping up the therapy. So step 4 is asthma not well controlled in double dose. Here you must learn that here we are not using LABA before 5 years. We are using only inhaled corticosteroid. So in step 4, if still with the inhaled corticosteroid low dose it is not well controlled, you continue controller and refer for a specialist assessment, because there are many differential diagnoses in children 5 years and younger, and they have to be assessed, and then only the further treatment has to be given. So this is the option 1. The option 2 in the children below 5 years and younger is considered intermittent short course, as we have seen. Then you can use instead of daily low dose inhaled corticosteroids, you can use daily LTRA, but that is as far as possible try to convince the parent that inhaled corticosteroids are much better than the leukotriene receptor antagonist. Or you can use intermittent short course up to step 2, because here the number of episodes are around 3 or more, but patient is yet not diagnosed as asthma. But in step 3, it is better to use low dose ICS with LTRA, because that will give a good result. But if still the patient is not controlled, it is better for a referral. Add LTRA, increase ICS frequency, or add intermittent ICS. So this can be done. But if the patient is not well controlled and you suspect asthma, it is in a child below 5 years, it is better to send the patient to the pediatric pulmonologist. One more important point is here, as needed short acting, we are using short acting beta agonist as a reliever therapy, and not as a not ICS with LABA as a reliever therapy in children below 5 years. So I hope you have this presentation will help you to understand the treatment of bronchial asthma in children from 6 to 11 years, from 12 years and above, and below 5 years and younger. And if we give this correct treatment to the patient and convince them properly, and also educate them regarding the allergen avoidance, then most of the children with asthma will have a better life, and all the prejudice against inhaler or about asthma will be removed from the society. Thank you very much.